Good morning. Thank you, chairpersons, for the kind introduction. I thank the Sri Lankan Endocrine Society for giving me this opportunity to share some of our experience in managing non-functioning sellar and suprasellar lesions. So I'll start with a case. This was a 25-year-old gentleman who presented to us with history of headache and decreased vision in both the eyes. He had visual field impairment in the form of bitemporal hemianopia, and hormonal evaluation showed panhypopituitarism. On imaging with an MRI, he had Hardy's grade C pituitary macroadenoma with a bleed on top of the tumor, which he was asymptomatic. So he had a non-functioning pituitary macroadenoma with panhypopituitarism. So some of the common presenting symptoms of patients with non-functioning sellar and suprasellar masses are those due to mass effects such as headache, visual disturbance, and symptoms due to pituitary apoplexy, as well as symptoms of pituitary hormonal deficiency. The visual field defects depend on the level of involvement of the visual pathway, and the most commonly affected site is at the optic chiasm, where the compression on the optic chiasm leads to bitemporal hemianopia. The differential diagnosis of non-functioning sellar suprasellar masses include non-functioning pituitary adenoma, which is the most common etiology, followed by hypophysitis, craniopharyngioma, Rathke's cleft cyst, arachnoid cyst, meningiomas, chordomas, histiocytosis, rare tumors like germinoma, sellar chondroma, and not to forget an ICA aneurysm, which should never be operated upon. Coming to non-functioning pituitary microadenomas, which are the most common and often detected on imaging for other reasons, the reported prevalence is about 7 to 41 per lakh population in a large UK series, and the probability of tumor regrowth in these patients is about 8% at 3 years and about 14.5% at 5 years, and only about less than 2% of them need pituitary surgery due to tumor enlargement. The hormonal problems in these patients are mainly due to anterior pituitary hormonal deficiency. AVP deficiency is rare in patients with pituitary adenoma. Pathologically, they are classified based on the immunostaining for the pituitary hormones as well as the transcriptional factors into gonadotroph pituitary adenomas, silent corticotroph tumors, and immature PIT1 lineage tumors. And those that lack expression of any of the pituitary hormones or the transcription factors are classified as null cell adenomas. Among the non-functioning pituitary adenomas, silent corticotroph and silent PIT1 lineage tumors are classified as more aggressive tumors. The posterior pituitary tumors include the pituitcytoma, the oncocytic tumors, as well as the ependymomas. So in our center, we do not use perioperative steroids for all the patients who undergo surgery for pituitary adenomas, and I think most places now have adapted this strategy as well. So we use perioperative glucocorticoids selectively in those who have HPA axis insufficiency, which is defined by the standard criteria. We also use perioperative steroids in the elderly, in those with clinical apoplexy, preoperative hyponatremia, as well as in patients where the surgeon reports that an adequate amount of the pituitary gland was not preserved at the time of surgery. So we audited the effectiveness of this strategy in our patients, in about 200 patients who had pituitary surgery at our center. Among our patients with impaired HPA axis, we use IV hydrocortisone on day 1, followed by oral prednisolone from day 2 onwards in those with impaired HPA axis. And those with an intact HPA axis, we check their serum cortisol levels for the first 3 postoperative days in the morning and on the day 7 post-op. So we compared the incidence of postoperative complications in the in those who had an intact HPA axis who were not perioperatively given glucocorticoids versus those who were given perioperative steroids. So what we noted was that only about 3.7% who had an initially intact HPA axis later on developed postoperative hypocortisolemia following transsphenoidal pituitary surgery. Despite having a protocol in place, there was protocol deviation in 15% of patients. 21 patients who were supposed to receive postoperative glucocorticoids did not receive perioperative glucocorticoids, and among them, 19% developed postoperative hypocortisolemia, emphasizing the importance of having checklists despite having proper protocols in place. Coming to the treatment of non-functioning pituitary adenomas, surgical excision, that is an endoscopic transsphenoidal pituitary surgery, is the standard treatment these days. The indications for surgery are visual impairment, worsening headache, or hydrocephalus. Complications, this is a recent paper on the postoperative complications of pituitary surgery. Minor complications are reported in about 13%, major complications in 8%. The most common complication following pituitary surgery is transient postoperative diabetes insipidus in about 10%, followed by permanent diabetes insipidus and panhypopituitarism, which develop postoperatively in about 3%, CSF leak and visual impairment are other problems in about 2.5%. Looking at the long-term problems, tumor regrowth occurs in about 46% who have a residual remnant tumor, and only in about 12% who do not have a residual or remnant tumor. Those who have a paracellular tumor to begin with, especially those with NOSP3B and above, or who have a large tumor remnant following surgery, would benefit from adjuvant radiotherapy or medical therapy. So we also looked at our data on silent corticotroph adenomas and compared them with other non-functioning adenomas. So we compared 62 silent corticotroph adenomas against the data of 238 other non-functioning pituitary adenomas and observed that silent corticotroph adenomas presented about 4 to 5 years earlier than the other non-functioning adenomas. They were larger at the time of presentation and more invasive, and also more likely to recur or progress following excision. And 60% of the residual silent corticotroph adenomas which were not radiated actually progressed to require further therapies. And early adjuvant therapy had a definite favorable outcome in comparison to those who did not have initial postoperative RT. A multivariate analysis identified male gender, MIB1 index more than 3%, and a silent corticotumor pathology as factors significantly associated with recurrence. Coming to the different types of radiation therapy, we now have fractionated radiotherapy and stereotactic radiosurgery, which can either be administered as a single fraction or as 3 to 5 fractions in hypofractionated radiotherapy. So in a single center analysis or comparing single fraction SRS versus hypofractionated SRT, the median dose of radiation administered by both the methods was about 20 gray. With a median follow-up of 5 years, tumor control was similar by both the methods, about 93%. Hypopituitarism at 5 years was also similar, about 20% in both the groups. And local failure rate was 5% with SRS and 8% with hypofractionated SRT. Hypofractionated SRT is preferred in those patients where the residual or recurrent tumor is close to the optic apparatus, where you want to avoid damage to the optic chiasm, and so you administer the radiation in 5 fractions instead of giving it as a single dose. Late complications were very minimal, and they were also similar in both the groups. Coming to the medical management, there is a meta-analysis of the use of gabagoline in non-functioning pituitary adenomas from 5 published studies, which included 187 patients. and it showed that tumor shrinkage was observed in 19% of these patients, and in about 50% it prevented tumor progression. So this would be one of the main objectives in patients where you would be interested in avoiding tumor progression, especially when a patient is not fit to undergo further forms of therapy. Adverse events were only reported in 2% of patients. Coming back to the initial case which I presented, so our patient was supplemented with thyroxine, prednisolone, and testosterone, and he underwent surgery. The histopathology showed a silent corticotroph adenoma, but on follow-up, he had multiple recurrences at different points of time along. So he needed multiple surgeries. So he needed 3 surgeries, and despite that, he recurred, and he also had radiation therapy twice. And following the last radiation, he also received concurrent temozolomide therapy in order to arrest the further regrowth of the tumor, and after that he has had no further recurrences. The next common etiology of non-functioning sellar-suprasellar mass would be a hypophysitis, which commonly presents with symptoms due to mass effect like headache, visual disturbance, or cranial nerve palsy. The combination of anterior and posterior pituitary hormonal deficiency would be a clue to diagnosis of hypophysitis. Such a combination is also seen in craniopharyngioma as well as pituitary metastasis. Imaging and hormonal evaluation would be required. These are the classical imaging features in patients with hypophysitis, that is a diffuse pituitary enlargement, absent posterior pituitary bright spot, a stalk thickening which could be nodular or diffuse stalk thickening, and homogeneous enhancement with contrast, presence of a dural tail, and also a parasellar T2 dark sign. These are some of the features which are useful to make an imaging diagnosis of hypophysitis. In patients with IgG4 disease, there is also a diffuse sinonasal involvement, which is a clue to the etiology of hypophysitis. The etiological workup should concentrate on looking at the secondary causes of hypophysitis, and sometimes a CSF analysis would be required as well, especially if tuberculosis, germinoma, lymphoma, or other malignancies are suspected. Anti-pituitary antibodies are non-specific. They may also be seen in patients with pituitary adenomas as well as healthy controls. Radiological investigations would include a CT thorax abdomen, and in some cases an FDG PET scan would be required. Biopsy is indicated when the diagnosis is unclear after extensive blood tests as well as radiological investigations. So in our series, over 20 years, we had about 87 patients with hypophysitis, of which 2/3 were primary hypophysitis and about 31% were secondary hypophysitis. Tuberculosis was the most common etiology of secondary hypophysitis. Among the primary hypophysitis, 10% were associated with pregnancy. Headache was the most common presenting feature in all the different types of primary hypophysitis. Visual defects and anterior hypopituitarism were more severe among those with primary granulomatous and primary necrotizing types of hypophysitis. With regard to the hormonal deficiencies, secondary hypogonadism was the most common hormonal deficiency in our series, similar to those reported in various other series, followed by secondary adrenal insufficiency and secondary hypothyroidism. Most of our patients were managed conservatively, either with replacement dose of steroids or just conservative management based on the symptoms. And high-dose glucocorticoids were administered only in about 25%. Despite that, 90% had good radiological improvement, and anterior pituitary hormonal function recovered in about 23%. So these are some of the patients who were managed conservatively as well as high-dose glucocorticoids. Both showed significant radiological improvement in due course. So this is a study from KEM Mumbai where they looked at early use of pulse glucocorticoid therapy where they gave IV methylprednisolone pulses for 3 days, 1 grams each day, followed by 60 milligrams of prednisolone for a month, followed by tapering over the next 5 weeks. In that, they noticed significant improvement in recovery of the anterior pituitary axis. That is, 86% of their patients treated with this strategy had recovery of their anterior pituitary functions as compared to only 43% who were treated by the conservative strategy. Again, looking at this data from a meta-analysis of 33 studies, which reported the data of 591 patients. 42% were treated with observation, 28% with high-dose glucocorticoids, and 30% with surgery. Again, anterior pituitary hormonal function improvement was noted in a larger proportion of patients who were treated with high-dose glucocorticoids. There was no significant difference in the recovery of diabetes insipidus among those treated with high-dose glucocorticoids or replacement glucocorticoids or other strategies. Radiological improvement was higher among those who had surgery as expected. Now coming to the next case, this was an 18-year-old boy who was brought to us with history of headache, visual impairment, and lack of secondary sexual characters. He had an arrested puberty, and on evaluation, he was found to have anterior panhypopituitarism, which included both anterior and posterior pituitary hormonal deficiency. And on imaging, he was found to have a large, predominantly cystic sellar suprasellar mass. So this boy also on CT, it also showed peripheral rim calcification, indicating a craniopharyngioma. So this was later operated and diagnosed to have an adamantinomatous craniopharyngioma. So coming to the cystic sellar suprasellar masses, these are lesions which predominantly contain fluid, and the fluid intensity may be T2 hyperintense if it is a CSF or low protein containing fluid, and if there is a bleed, it could be T1 hyperintense in the acute phase, and fluid which contains high protein or oily contents is again T1 hyperintense. The differential diagnosis would include craniopharyngioma, Rathke's cleft cyst, arachnoid cyst, cystic pituitary tumors, etc. Craniopharyngiomas account for about 1% of CNS tumors. They have a bimodal age distribution occurring in childhood and later on again in the 6th and 7th decade. They have a combination of anterior and posterior pituitary hormonal deficiencies, and treatment is with surgery followed by radiotherapy to the residual tumor. Arachnoid cysts originate from a defective diaphragma sella through which the arachnoid membrane herniates. They often present with mass effects. They are purely cystic lesions and they have to be treated with surgery. Rathke's cleft cysts are benign lesions arising from the Rathke's pouch. Their signal intensity is again variable depending on the protein content of the fluid. A high protein content fluid will be T1 hyperintense, while a low protein content fluid would be T1 hypointense. Treatment is with marsupialization of the cyst. Rare cysts include dermoid and epidermoid cysts. The epidermoid cyst has a classical appearance of being hypointense on T1 and hyperintense on T2 weighted images. These most commonly occur in childhood. Meningiomas are another common entity which we encounter in clinical practice. They also present with mass effect, mainly with headache and visual disturbance. Usually the hormonal functions are intact prior to surgery. On imaging, they are isointense on T1 and T2 weighted images and show avid homogeneous contrast enhancement. And they have an enhancing dural tail. The treatment is with surgical excision, and most often they would need adjuvant radiotherapy. Germinomas are other rare tumors affecting the sella, having a subacute or slow presentation with headache, visual or neurological symptoms. The clue to diagnosis would be elevated CSF and or serum beta HCG levels, And in the MRI, they may have multiple lesions as well as drop metastasis in the spinal cord, which are close to the diagnosis. Treatment is usually with systemic chemotherapy along with radiotherapy. Chordomas arise from transformed remnants of the notochord. The epicenter of the tumor is predominantly at the clivus in the tumors arising at the base of the skull. They are aggressive, locally invasive, and quite often have a poor prognosis. On MRI, they are T2 hyperintense with a heterogeneous contrast enhancement. Treatment is with a maximally safe cytoreductive surgery followed by radiotherapy, but recurrence is common. Chondrosarcomas are again another rare tumor arising in this region. They are predominantly hyperintense on T2 weighted MRI and hypointense on T1. And on CT, you can see destruction of the surrounding bones with chunky areas of calcification. Treatment again is with surgery and adjuvant radiotherapy. Histiocytosis are hematopoietic diseases with accumulation of CD68 positive cells with admixed inflammatory infiltrates. They can present with tumor-like masses in the pituitary, choroid plexus, and other regions of the brain, as well as lesions in the bone. So this is one of our patients who presented with a hypothalamic mass as well as swelling in the jaw with loss of multiple teeth and swelling over the scalp. He had an expansile lesion over the parietal region. This is histiocytosis, and when it is solitary, it is treated with surgical resection or low-dose radiotherapy. When it is multifocal, it needs systemic chemotherapy. Pituitary metastases are an uncommon complication of malignancy, mostly due to malignancies from the breast, lung, renal, prostate, or colon cancers. Presentation is usually with headache, cranial nerve palsies, or diabetes insipidus. Treatment, if it is a solitary metastasis and resectable, surgery may be attempted. Otherwise, most often needs radiotherapy or systemic therapy. Among the non-tumorous lesions, one should keep in mind an internal carotid aneurysm, which can be seen in the Sellar. So this was a patient who came to us like a prolactinoma. She presented with headache and visual disturbance with third cranial nerve palsy. Her prolactin level was very high, 1470 nanogram per ml, with secondary hypothyroidism and hypogonadism. Initially, we thought it was a cystic degeneration on one side, but subsequently, after treatment with cabergoline, we noted that there was a flow void on T2, and there was layering around it, suggesting an ICA aneurysm. So a partially or completely thrombosed aneurysm would give a high signal intensity on T1 weighted MRI, whereas an aneurysm with recurrent hemorrhage or thrombosis would give an onion skin or a layered kind of appearance. The diagnosis is confirmed by CT angiography or digital subtraction angiography, and the treatment is with endovascular occlusion. So to conclude, a variety of lesions can present with solid or cystic sellar and suprasellar masses. The clinical presentation, the pattern of hormonal deficiency, and the specific imaging features would help us characterize these lesions and thereby initiate appropriate management. Hypophysitis has been recently more recognized as a cause of hypopituitarism as well as pituitary mass lesion, and an internal carotid artery aneurysm should never be missed because it can lead to catastrophic events if surgery is attempted. Thank you for patient listening.